Welcome to the Registry Insider. I'm Bill Seifarth, CEO and Executive Director of the National Registry of EMTs. And today I have with me Dr. Braxton Morrison. He's a board member at the National Registry of EMTs, also a paramedic, and has been pretty heavily involved in emergency services. And his passion, as well as his dissertation and PhD, is in crisis intervention and traumatic stress with emergency services clinicians. And that's a really important topic that certainly the EMS community in particular needs to be perhaps a bit more aware of. So thanks, Braxton, for spending some time with me today to talk a little bit, one, about your passion, your dissertation, but also let's get a little bit into the subject and see how we can perhaps get some services or resources to EMS and a profession that desperately could use those resources without question. So tell us a little bit about to kick off your background, your passion, kind of what got you into it, and then we'll get into more as far as, how does that apply to EMS today?
Sure. Thanks, Bill. I appreciate the opportunity to be here. Background started in 2012 when I joined the Army. I admittedly got discharged with post-traumatic stress disorder and chronic pain. I then joined the world of law enforcement and EMS immediately after getting out of the Army, and did what emergency services personnel do, and we layered trauma on top of trauma. And when you do that, it gets very hard to treat, and it gets very hard to seek help for that the longer that you go on. So as I entered the world of emergency services as first an EMT, of course, and a police officer, worked for both for about 8 years. Obviously became a paramedic as well. And I saw my friends, my brothers and sisters, if you will, struggle with the same type of pain from difficult calls they endured. Oftentimes saw no help given to them or offered to them. And it just truly started to break my heart.
Yeah.
So 2017 rolls around and I start offering crisis intervention to emergency services personnel, kind of unofficially through a critical incident stress management model. 2020, I co-founded a nonprofit team that we provide crisis intervention to any emergency services worker that happens to be there.
Is that anywhere in the country or anywhere in your state? Or
yeah, so in the state, we're specific to a county, but we cover different counties under a region type of service. Yeah. But if I had the resources and was able to travel anywhere in the United States to provide services to them, I certainly would. So then 2021 already rolls around, and I just went a little bit further and truly pursued my passion into a PhD in human services with an emphasis in crisis intervention. And I just can't tell you the amount of things I learned and didn't learn. Also, in my dissertation, it was very obvious the amount of research that's been done for fire and law enforcement. Yeah. And even telecommunications now.
And how much has been done for EMS?
Not as much, Bill, not as much. And when the research that's done for EMS, they're often grouped together. Only 37% of fire services in the United States don't provide EMS. So that is a significant amount of fire services that are providing EMS. And a lot of the times, and I'll just quote what I've heard, you're a firefighter first, you're a clinician second. Always have your fire gear on the truck with you. Police officers, you're a police officer, paramedic, police officer, EMT. And then to do other professions, telecommunications, they often like some type of field experience, not required, but it helps to know what's going on in the field, to answer the phones. Something else that I do, death investigations, at least in the state of Iowa, which is a medical examiner state, and then you have coroner states, it's required to have a law enforcement or healthcare background. So I don't know any EMS clinician, for that matter, that works one EMS job.
The data do support that in terms of data from the National Registry anyway, in terms of multiple roles.
Absolutely. And so it's with anything else, the more you drive, the more risk you have of being in a car accident. The more jobs you work in emergency services, the more risk you're going to be at being exposed to trauma. And when we don't have anyone offering them help, and even when there is help, Data from that I supported in my dissertation shows that it depends on the organization. It depends on the type of environment that the clinicians are in. If they don't have supportive colleagues, if they don't have supportive supervisors, they may still not seek help, even if it's available within their agencies.
Yeah, it's unfortunate, and the reason why I asked the question I did, but how much research has been done in EMS is very little. And how many resources are available to EMS compared to fire, law enforcement, nursing, telecommunicators?
I can't think of a specific one off the top of my head.
That's specifically geared
specific to EMS.
Yeah, which I think that's the call to action, is to make sure that we, as a profession, as a broader EMS community, get these kind of resources in place, and potentially the concept you have local within your state, how can that potentially be replicated? Can it be? I assume it can be, correct?
Yeah. Critical incident stress management is a specific type of crisis intervention model. And to be honest, I don't mind which crisis intervention, or the bigger term that's coming around now, peer support model, EMS clinicians get, but they need something. And peer support is being validated through the research that it can be as effective, if not more, if the circumstances and their environment are right, as therapy or counseling is. Even though the goal is not to treat, with peer support, it's to alleviate and mitigate. So critical incident stress management just, to me, works because it's a peer-based crisis intervention model. So I've been on the street where you've been, so I can empathetically relate to what you're going through. That's why I think it's a great model. But as far as replicating that, that's an international program. Anybody can go get the training for it. What I think is more important is doing those peer-based models, but it's developing culturally competent clinicians. And those are licensed behavioral health, mental health clinicians, the social workers, mental health counselors, psychologists, psychiatrists, because when I find out that I need help and I go to a clinician that's not culturally competent and I tell them the things that I've seen on the street working as an EMS clinician, they've never heard anything like that before.
Yeah, the level of stress that an EMS clinician deals with in a week is sometimes more than most people deal with in a lifetime.
Absolutely. And so, we're helpers, right? We're here to help people. We're here to fix things. That's our job, and it's our personality type. So when we go in and the clinicians aren't prepared to hear what we have to say, that can be really stressful back on us, and it doesn't make us want to go back for a second visit.
And so let's talk a little bit more on this culturally competent mental health professional. So elaborate a little bit more in terms of what that is. I think it's pretty obvious, but I want to make sure we get absolute clarity on that, because the last thing you need to do is go to a psychologist or a psychiatrist or a counselor or a therapist, and they don't even know the first thing about EMS and the trauma that we see. And it could be startling to them too, and they're not capable of dealing with it.
Sure. And just, as we talk about the recognition compared to law enforcement and fire, the other two big emergency services professions, they have Association of Police Psychologists. Firefighters have their own psychologists, mental health counselors.
And what does EMS have?
There is no association or recognized body advocating for culturally competent EMS clinicians, to my knowledge. But what that means to me is you have either done the professions, you've been in it and then went on to become a licensed clinician, or you've taken the time to truly immerse yourself in that culture to become culturally competent. So if you haven't worked in it, you've done ride-alongs, you've went to the station and developed relationships, you've met the EMTs, the paramedics, the clinicians that are working, you've given them cards and you've read articles and you've read books. You've done whatever it takes to immerse yourself in the culture to truly be recognized, not as culturally competent by me, but as culturally competent by the EMS clinicians that you're working with on a day-to-day basis, or that you want to work with on a day-to-day basis.
So what is the exact call to action then for us in EMS as someone who, you've completed your dissertation in this, it's your passion. What do we need to do nationally at the EMS level, nationally, I should say, to really change this? Again, EMS doesn't have what fire has, what law enforcement has, what nursing has too, what telecommunicators have. How do we change that? How do we bring about the change? What do the listeners here potentially need to get involved and help you
Sure.
to be the champions of change and to help the profession that we're all a part of and we love dearly?
I think there's a couple different things, Bill. I think the first one is there is definitely a need for combined research of emergency services workers, police, fire, law enforcement, EMS, telecommunications, but there's also a need to have that research separated out. And we need to start researching EMS as its own profession, not as a sub-profession of fire or a connected profession to law enforcement. They deserve their own research and their combined research just as any other emergency services profession has. The second thing that I would say is organizations, starting from the top and starting from the bottom, the supervisor that's been there 50 years and the clinician that started today have to work together to meet in the middle to, sound cliche, break that stigma, because it is still, as of last year, supported in the research that organizational stigma will come back on EMS clinicians and emergency services workers and the other way around. If the stigma starts at the bottom, it's going to go up the chain as well.
So when you say the stigma, like to say I need help or I've got some problems, I've dealt with a lot of trauma personally, professionally, and to call for help creates the stigma.
And we think that that's going away or that it's gotten better. And it may be getting better, but I can assure you that it is still everly present. And the last thing would be for, you can go out today. I started this in my community in Eastern Iowa, and I just took the Fraternal Order of Police Clinician Vetting Guide. I altered it to my needs. And if a clinician wants to be on, it's my list right now of culturally competent clinicians. They have to do about a 45-minute interview with me via Zoom or in person, and I add them to the list. And I to this day have a psychiatrist, psychologist, several social workers, mental health counselors, and none of them have less than 5 years of working with emergency services workers. And they almost all will get you in less than a week if it's a crisis, which is quite a difference to the 6-month waiting time we often hear nationally. None were more than 3 weeks if it wasn't a crisis. Mm-hmm. And so to my point, we need to start, and anybody can start this. Any EMS clinician, any emergency services worker can start a truly vetted list, not someone that can go on a website and sign up and say they work with emergency services personnel, but a truly vetted list making clinicians prove why and what they've done to immerse themselves in the culture to be considered culturally competent. And those lists need to start being developed all over the United States, not just in Iowa. And what the difference is between my list and other lists is the vetting. To my knowledge, I don't know other places that truly vet clinicians. I know several websites you can go on and sign up and say that you work with emergency services, but there's no proof that you're culturally competent, and that's the key.
Good solid advice and good recommendations in terms of path forward. So 2 other questions I have for you in our time remaining. The first is, are there national resources or websites that folks can go to learn more about cultural competence, and
Sure.
2, maybe what others are doing? And then the second question I have for you is, if you wouldn't mind, give us an email address which we can put in the comment section that folks can get in touch with you
Sure.
if they'd like to learn more about this. But anyway, the first part, what are some national resources that are out there?
Sure. Well, one that may not be as obvious is there is so much open access research that anybody can go and do their own research and look at their own data to support what I'm saying. The others are 988 came out in 2022. That's often referred to as a suicide prevention line or a crisis line. You can just be having a bad day, call and text 988, have a quick vent session, and go about your business. It doesn't have to be a line that you call for a crisis or someone experiencing suicidality. Other ones, find those culturally competent clinicians and do it today when things are going well, when work is going well, when family life is going well, because in emergency services, we're unfortunately known for things like domestic violence, divorce, alcohol and substance use, not good things. So when those things add up, cumulative stress, and we have all those life stresses going on, and then we experience a traumatic call, that call may have been able to be dealt with, but now we have it boiled up to the top from cumulative stress already, and so we just kind of go over the top. Those would be my recommendations, and I just can't emphasize cultural competence enough in the clinicians that you choose. And internal peer support programs, they don't have to be trained in a crisis intervention model such as critical incident stress management, but it's certainly helpful when they are, so they know what they can do internally and when to refer to an external crisis team to support them. And then an email, you can contact me at bmorrison, B as in boy, MORRISON, at NREMT.org.
Okay, great. Well, Dr. Morrison, thank you for spending time with me today to talk about this important subject that clearly we as a profession have got a lot of work to do. Our clinicians are unfortunately faced with a lot of trauma, and there's not many known resources for them to go to deal with those situations, and that's unfortunate. And hopefully, this podcast, this episode, will be an instrument of change nationally. So I appreciate your passion, you sharing your story with us, as well as letting us know your thoughts in terms of how we can improve this for the profession that we all love and serve, and hopefully can bring about some positive change.
Thanks, Bill.
Thank you. And thank you for what you do. And as always, stay safe. Thank you for joining us for this episode. If you wouldn't mind, please click the like and subscribe buttons, as well as the notifications so you can get notifications of upcoming episodes. Also, for the latest and greatest happenings of the National Registry, feel free to go to NREMT.org. Thank you very much. And again, stay safe.